Okay.
Hello, everyone, and welcome to the Journey to Healthcare. Today, I have special guest with us today. We have Dr. Haider here. He's a GP from the UK. Would you like to introduce yourself?
Hi. Thank you for the for having us on this today. My name is Haider, as you said. I'm a UK trained family medicine doctor, or GP as we call it in England. My background essentially is a GP that has a special interest in dermatology. So I do a bit of both. And I've just left the job where I was doing a bit of sports medicine as part of my full-time GP job. I trained in Manchester, but I emigrated from Sweden, and before that, the United Arab Emirates. That, in a nutshell, is a little bit about myself. Yeah.
All right. So the big question here, what is family medicine or GP?
Yeah. So the nomenclature, the name differs depending on where in the world you are. In the Middle East, we're called, and in the States, we're called family medicine doctors or physicians, or GP, general, or a family physician, essentially. So we are doctors who some would say know enough about all the different various aspects of medicine. So we know how to recognize the issue that we're presented with and know how to safely handle it or refer on to a colleague in that specialty. For example, if someone came that was breathless, we would take a thorough medical history, and 80% of the time, a good medical history will pinpoint you in what direction you're going in. Occasionally, if that breathlessness, if we stick with that scenario, it might be a virus or a chest infection, and we would safely treat that for the most part in our clinic rooms. Occasionally, depending on the signs and symptoms, we might think that it might require more than outpatient department type treatment, and we'd refer those in after communicating with a colleague in secondary care. So without digressing too much, essentially, a GP is someone who has a wide grasp of general medicine and surgery, without being a particular specialist in one area per se, although increasingly with academic GPs or portfolio GPs, as we're called, you can become a specialist in an area. And I try to do that to an extent with dermatology, which I'm sure we'll talk about later.
All right. So that something also about family medicine is that you see patients from all ages, right? You don't
Absolutely.
have a specific age group, because before I heard this saying that if you are not sure whether to go to pediatrics or internal medicine, family medicine is another great specialty because you get to see all the ages.
Yeah, I mean, absolutely, I would agree with that. It depends again. I've worked a little bit in the Middle East as well as for the most part in the UK, and I've got friends that work all over. Depending on the private care model, you might be a GP that sets your own boundaries and say, I don't see under twos, send that to the pediatrician because they'll happen to be next door and everything's private. But certainly what I'm used to and what most family medicine doctors or GPs are used to is that you see everything, whether it's a newborn to someone who's in their 90s and beyond. And as you say, it's one of those things where if you can't decide whether to choose a particular specialty, you may well go for a GP because you get to do a bit of everything.
Yeah. So what is the path to become one?
Sorry, say that again.
The path to become one.
I see, the path to become one. In the UK, of course, you go to medical school first. After which you do 2 basic years, which we call the foundation years. That's FY1 and FY2. Previously, or in different places, you might have heard a first-year doctor being called a house officer, and an HO or a SHO for the second year and beyond, which is a senior house officer or slightly more senior doctor. After the first 2 years, if you've applied to general practice and you've got into that specialty training program, because it is considered a specialty in the UK, essentially what happens then is you've got 3 years of practice, after which you have 2 major exams, a written paper, or MCQ paper, followed by a practical exam or an OSCE. And after that, providing you satisfy the assessment through those 3 years of specialty training, you become a general practitioner. And then every year you have to, like in most specialities, do enough CPD. So, learning to show that you're keeping up to date. And if we're not talking about the UK per se, for example, in Canada or the States, you have to do a degree first, then get into medical school, and then do your specialty training, which sometimes is longer than 3 years. Not to digress too much, but some of my colleagues in the UK didn't want to finish their training very quickly in the 3 years after the basic training. So they opted to do GP Plus, which is where you do an extra year, for example, or longer in a specialty that you're interested in, whether that's palliative care, dermatology, or pediatrics even. They've added a lot of these things in there.
Oh, interesting. So it's kind of like a fellowship in the US.
Yeah.
All right.
Perfectly. Yeah, I think that's a perfect way of describing it. So if you were somewhat impatient like me, I wanted to finish the 3 years as soon as possible because I'd planned out my career really early on. And during I think my second year of working as a GP, when I was fully qualified, I did a full-time distance diploma to start doing my dermatology training.
All right.
But yeah, others would have a much more sensible approach, I think, and take time out and do it after or during the training.
I see. You touched upon dermatology. I want to ask first, what sparked your interest to become a GP, and more specifically for dermatology?
Yeah. So first of all, I never wanted to be a general practitioner because I fell into the whole rumor that general practitioners are lazy. They just write sick leave, sick notes, or throw antibiotics at everything. And I was almost someone who was book smart, and I wanted to unpick complicated problems. This is very early on when I was a first-year medical student. You have these perceptions that aren't always correct.
Yeah, they always say you enter med school wanting one thing, and then you change your mind a million times, then you choose a specialty.
Absolutely. And that rings true of a lot of medical students, including me at that time. So I went in thinking I'll do my rotation because in the program I was in, you had to do a rotation in general practice for 4 months. And then I would never touch it again. But every single time I was in touch with a general practitioner, including my own when I was unwell, they knew everything. Like I had an orthopedic problem once, they knew exactly what it was, how to treat it. They just didn't know how to operate because it's not their field. And when I met the specialist, it was the same management plan, et cetera, et cetera. So why I chose general practice is I wanted to be involved in various aspects of medicine, including general medicine, which was one of my biggest aims, really. I wanted to be a med reg and a medical consultant. But I also wanted to do a lot of other things, like have a subspecialty, do teaching, and all these kind of facets of a medical career that may perhaps be a bit more difficult if I'd chosen another specialty. That's how I rationalized it anyway. And with respect to dermatology, it was something that I found very difficult. I still find it somewhat difficult, but it's certainly got easier because I focused on it. So most patients that would come with dry skin or irritated skin, inflamed skin, I noticed a lot of my colleagues and seniors would often give them potent steroids and then hope it goes away. But they'd come back and eventually they'd all be referred to a specialist, a dermatologist. And of course, in the UK, where medicine is free at the point of access, it takes a long time. And I noticed patients were suffering in that way. They'd get frustrated. They'd come back to the GP and they'd get more steroids. And in the long run, when we get letters back from the specialist, they summarize the journey of the patient to that point, and then they educate us or confirm our initial diagnosis. So that was the main reason. It was more to, the dermatology question rather, it was more to make me a better doctor and to help reduce the the patient journey. And the more I did that, eventually you can't really escape it. It gets interesting. You see things in clinic where you think, I know exactly what that is now. I don't need to refer them anywhere. And very quickly after that, I became the dermatology lead for one of the three practices that I used to work for.
This is absolutely fantastic. And
It's good fun,
yeah, that is really interesting. So, so what's your favorite part of the job?
So this may sound cliche, but the best part about my job is it doesn't feel like a job. It's very serious. There's a lot of responsibility, but time flies. You'll get, that's not to say that the job isn't hard and we don't work extremely hard. There's, as I say, tons and tons of responsibility, but I go away feeling I've helped most my patients a little bit at least in making their life a bit easier. So you go away feeling very good, even if you spent 10, 11 hours at work. And I'm lucky in that the colleagues I work with are generally really fun. We're all in it in the same boat. So I've always said I go to work to do a job, and then if I make friends along the way, it's a bonus. And so far, I've had the luck to have a lot of bonuses in that regard. So that's probably my favorite part, the interaction with both patients and colleagues. And sometimes depends how your day has gone. If you've got an easier day or you've just had the run of luck, let's say you've had really simple, straightforward patients and you finished a bit earlier, it's one of those jobs where you can actually dip in and see some of your colleagues' patients, help the medical student or the junior doctor, and then, guide them as well, because there was a point where I thought I'll never be able to keep this 10-minute limit that they give us to see patients. And then very quickly you think, I'm finishing 7 minutes without rushing the patient and saying, do you want to talk about something else? But that comes with rapport and the patients knowing you and, knowing they can talk about more than one issue because you know their medical history. Whereas if you're new or a locum, sometimes patients are frustrated. They come with a lot of problems and it took them probably a long time to see you that one time. Whereas I've got the luxury of having worked in the same place for over 3 years. I've moved since, but whilst I was there, patients know you, and if they've waited a long time, you're very, like, I find it very easy to be truthful with patients that say, let's say they've got a list of 5 problems.
Mm-hmm.
I'll say something along the lines of, look, to give your problems the time and attention they deserve, why don't you pick 2 of the ones you think are most urgent, and I'll book you in whilst you're in this clinic for a follow-up for the other things. That way they don't feel like they have to navigate through the sometimes difficult access to the GP.
Yeah.
And so using my communication skills, even though I'm rambling at the moment, is probably one of the favorite parts of the day for me.
That is great, and I think that just give us like a point that like if you preserve through it all, it will be worth it. Like as you said, you'll see a lot of progress, and then you'll enjoy the job more. Because usually people like say healthcare is hard, which is hard, but that joy of helping people is quite prominent. So you don't have to be carried away from it, to whoever's watching this.
No, absolutely. I mean, the thing is, look, I think regardless of whatever specialty you go into or your listeners go into or any junior doctor goes into, it's all about balance.
Yeah.
So I had colleagues who stayed in the library throughout medical school, got amazing grades. And then you had the likes of me who helped run a basketball team for around 10 years at medical school. I was playing basketball and training 3 times a week, but I paid attention in class and I had a really good balance. I probably could have got better grades if I if I gave all that up and just stayed in the library. But for me, it wouldn't have been as enjoyable, and I certainly don't regret it. But I think the important thing is, regardless of what specialty you go into, make sure that when you struggle, and we all struggle in some way or another, even when you're getting things right, you might think, gosh, that was very difficult, or that took longer than I thought it would. Or even being afraid of, I don't know what's going to come through the door. because general practice is like A&E without all the fancy bloods, x-rays, etc. Sometimes it's good to have a debrief, even every day, with a senior, a colleague, or even another healthcare professional. So my support system for a large part was the nursing staff. They'd been in healthcare far longer than I have been still, and they'd seen it all. So being just a human being saying to someone, do you know, this is tough, is really good, because they've got insights and they see things perhaps differently to the way we would have seen it. But what I'm trying to say is, you're still a medical student, I believe. Is that correct?
Yeah.
Yeah, that goes so quick. And you'll look back and think, I can't believe I was having this chat about general practice or whatever it is. And then you realize it's not that bad, actually.
Yeah. But now it feels very slow. But yeah, I'm sure
Yeah.
down the line, down the line, I will understand that.
Yeah.
Okay. So regarding family medicine or general practice, what are some myths common myths you want to debunk about the field?
So I think I very briefly touched on that before, in that general practitioners are perhaps lazy, or they don't know enough medicine, so they've kind of gone into a safe profession, or that it's not glamorous, boring, etc. All those things, or because I know you're studying in the Middle East, where sick leave is not as common as or is different to how it is in Europe. Um, the general practice is what you want it to be. So some people will work full-time just in clinic. And if you do that, and there's certainly nothing wrong with that if you like that kind of thing, you will see a fair amount of pediatrics, and probably around 60%, about 40% of dermatology cases. So those are the things you need to be good with anyway. And a lot of what we call social prescribing. I don't know if you've heard of that term before.
No.
So, no. So social prescribing is things to do with, let's say you're receiving government benefits, and you've got what we call social housing. You heard about that kind of stuff?
Yeah.
So it's a big struggle, because worldwide now we've got austerity, which means things are more expensive, inflation's high, so people can't afford, well, their wage doesn't match their living habits, unfortunately, despite them doing the best they can. Like the energy crisis, things have gone up more or less double in the UK and Europe, at least. I'm sure it's hit the rest of the world also. So the knock-on effect is that people in working class people, as well as those who are on benefits, where they are either disabled or there's something else going on where they can't work full time or they can't work, they're reliant heavily on government help. And often they'll come to a general practitioner and they'll ask for an extension of their medical sick leave, so they can continue caring for their own personal health, or if they're a carer full time, they care for a loved one, etc. Or they'll need bigger housing or any number of such things. That takes up a lot of general practice time. Or moving away from that, let's say someone's had a hip replacement from a fall, they've had the operation, and they shouldn't be in hospital anymore, but they're not safe to be at home. The general practitioner gets involved in trying to find that middle ground, where we call it convalescent care, the limbo land, if you like. Again, some GPs specialize in that, where they work with nursing homes, or where they work with convalescent care, which is this middle ground where they go in there, they get reviewed, and they hopefully through there go back home. That aspect wasn't well taught, I felt, when I was a medical student. I never saw my GP do it, but behind the scenes, that takes up a lot of the time. So the myth, perhaps, there's another myth in that. So that's the boring bit, some would say, but I love social prescribing, because if you do it right, your patients won't be on your case as such, because they'll trust you. They know that you're doing due process and you're doing the best you can. And the best way to get patients on board is by being open and honest. I am digressing a bit from your question. I'm mindful of that. one of the myths is that all general practitioners in the UK make over £100,000 a year as their wage. I wish that was the case. It isn't. I'm sure some do, but they must be having no time off and doing some extraordinary long shifts. Most and again, GP is rumored to be boring, but for example, my job where I do some clinical medicine, I do medical education work, I do the dermatology thing on the side, and I try to teach through Instagram, much like you do, which is great to see. Other colleagues, they're actually A&E registrars because they've sat those exams, and they do 3 days of general practice and 2 days of A&E medicine. Others do community pediatrics and general practice. So even one of my colleagues does carpal tunnel surgery as a GP. 1 day a month, they get a clinic, yeah, in the hospital. So it's unusual, right?
Yeah,
I
hear that.
So I asked about that. They have to do 40 carpal tunnel surgeries under a consultant.
Mm-hmm.
Then they get signed off, and they get a bespoke or a day a month where they do a list of carpal tunnel surgery. Others I know are, we call them gypsies or GPs with special interest. I know one in gastro that does the scopes. Yeah, they do
That's
gastro.
really interesting. I'm not.
Yeah.
Yeah.
So that's what I mean. You do what you like, whereas I'm not aware, and I might be mistaken, but I don't think a traditional consultant in the hospital, so internal medicine consultant in the UK at least, I don't think you get the option of doing a little bit of this, a little bit of that. But times are changing. But for general practitioners, I even know one who's a cardiology specialist. He works with the consultants as someone who does cardioversion to anything you can imagine. But he's done a lot of training, of course. It's not just a diploma distance-wise and you tick the boxes. So my top three myths essentially would be general practice is boring. Certainly isn't, but you need to know what you're getting into. And that's because you can subspecialize. You can be really heavily involved in the community. So you can essentially be based in a nursing home if you like and do ward rounds independently. You can do surgery. Or you can be a commissioner, which is like a manager in, in the community working with the NHS to spend the budget appropriately. And yeah, so there's a lot of facets to general practice.
Interesting. I mean, I learned a lot. There were many things, especially the specialization part. So
yeah,
like,
absolutely.
that's really interesting. So
So one last thing, sorry, you can, if you're interested, a lot of people ask me on my Instagram how GPs get involved with sports, and it's quite unique because in the city where I live in, I'm lucky that there are quite a lot of soccer teams that are around. My interest was never soccer, it's basketball. So I got into that, and I ended up being a sports medicine doctor for a local professional team. And it's super easy to do, and it caters for GPs. It's quite easy for GPs to get into.
Okay.
But that might be another chat. Yeah.
Yeah. So basically, the options are unlimited. That's to sum it up. Yeah.
Yeah.
Fantastic. So, to sum it up, what are your advice for aspiring GPs or family medicine doctors watching this?
Yeah, I would say the best thing to do really is to, if you're okay, you have to experience it, not as a patient. So I know things with COVID have been a bit difficult to shadow, but I know here in Manchester, at least, if you're a medical student particularly, or even a junior doctor, you won't have a problem getting some study leave or using your personal time to sit in with your local GP to observe. So I would say speak to a few GPs. Don't get your view of one alone. Not everyone does sports medicine with dermatology and medical education and the job. Others are perfectly happy working part-time and having a really nice life. Because the good thing is, despite the economic crisis we find ourselves in, you can do a part-time job, which my friend does, and live a completely content life. But my best piece of advice would be speak to more than one GP. Speak to one who you know does something else, like surgery or any of the other specialities, and speak to someone who, or a couple of someones who just do normal general practice, and ask them maybe to tick their highlights and lowlights of the job. Yeah, that's would be my piece of advice. For me, I can't see myself doing any other job, even if I could go back and choose a specialty. Can't speak today, and choose a specialty rather.
Yeah, and that's the most important thing, because I believe that when you like something, you will excel in it. If you have the passion and all that, you'll be willing to go, 110%. So that is
Absolutely.
really important. Yeah. So thank you so much for this really fruitful episode. Like,
Pleasure.
it's been really lovely chatting with you, and I hope you have a lovely day.
You too. Thank you.
Thank you.